Good afternoon, everyone. Good morning, depending on where you are. Welcome to our webinar on lessons learned from collaborative models to enhance decision making. My name is Taryn. I'm the manager of the Alliance for Health Policy and Systems Research here in Geneva, and I'm joined here by my colleague, Dr. Etienne Langlois, who is the project officer who has been overseeing this work over the last couple of years. We have a very exciting presentation this afternoon from 4 different individuals working on 2 different projects. We have Victor Montekio from Mexico, who will be joined by his colleague Miguel Orozco from Nicaragua, who will be talking about work that they've done to establish a community of practice for implementers in the field of maternal, newborn, and child health. We will be following that presentation with Taryn Young from Stellenbosch University in South Africa, and I believe also Dr. Pierre Ongolo from the University of Yaoundé in Cameroon, who are going to be talking about their work that's focused on a model to bring together policymakers and researchers through a buddying process, which is the title of their project, Buddies. And then my colleague Etienne will be reflecting a bit on the cross-cutting lessons that have been learned throughout this entire process. Just to give everyone a little bit of information about how this webinar is going to be working, unfortunately at this point we're not going to be able to have everyone participate verbally. So what we're asking you to do is to make note of your questions, and if you could send your questions to alliancehpsr@who.int. We will then forward those questions to the presenters, who will then be able to respond to those questions, and that's how this will work. So if you could just make note of your questions, send them to alliancehpsr@who.int. We will then respond to the questions after the presentations. So what we'll do is we'll start with a presentation from Victor and Miguel, and then we'll follow that by a presentation by Taryn and hopefully Pierre, and then Etienne will make a presentation, and then we'll open it for discussion. We will have about an hour for this entire session, so we do hope that, and we want to leave time for questions, so each of the presentations will be about 10 minutes, and so we will have about 25 to 30 minutes at the end for questions and discussions. And we do look forward to having this as a interactive session, so we do look forward to your questions. At this time, I think I'm going to stop my overview introductions and just hand it over to Victor and Miguel, who will talk about the work that they've done over the last couple of years in Mexico and Nicaragua. Victor and Miguel.
I'm terribly sorry for this inconvenience. This is the name of the project we've been working in Mexico and Nicaragua. Can you please pass the next slide? These are the main objectives we had in the project. The idea was to strengthen personnel's capacities in a series of things. First of all, we wanted to identify and prioritize implementation problems in the maternal health problems that we're working in. And after that, we had several training activities to strengthen their capacities to acquire, analyze, adapt, and apply scientific evidence, to design and conduct implementation research protocols, and finally, this all entailed collaboration with research institutions to integrate evidence into programs. That means this was the collaboration between them and us. Can you please pass the next one? Next slide, please. Yes, so the project was all organized around 3 axes: an evaluation, a capacity strengthening, and a capacity development axe. The evaluation was something that really concerned mostly the research team, and then capacity strengthening with these 3 main activities: the formation of communities of practice, selection and training of the leaders of these communities of practice in implementation research and evidence-informed decision-making, and the training of all the members of these communities of practice in implementation research. And these entailed the 4 boxes that you see below. That was mapping maternal health programs, implementation problems, making a literature review in order to give scientific support to what they were doing, then evidence-based problem formulation and implementation research project development, and then the conduction of the implementation report projects. The next slide, please. This all meant that the center of the whole project was the building of communities of practice. As you can see, the 3 boxes in green, the capacity strengthening activities, they are all concerned with communities of practices, and the 4 main activities were all developed by the communities of practice. Next one. A very important thing is that how we conceive these communities of practice. In a very simple way, we work with them considering that communities of practice are groups of people who share experience and interests. Communities of practice, they give formal context for the sharing of these experiences and knowledge, since people working together usually meet and exchange different ideas, but they very seldom do this in a very formal way. So communities of practice are intended to provide this formal context. There's 4 kinds of people that integrate communities of practice. First, we can talk about a champion. The champion is not necessarily someone who is directly working with all the other members. A champion is someone who has a key position inside the health system and who will work to foster all the activities of the community of practice. Then we have a facilitator who is indeed a member of the community of practice, a very important member, because this person will work as the liaison between the research team and the other people in the community of practice, which in fact are what we have as a 3rd category, that's the members. And then among the members, we work to identify the most active people who will be called leaders. The next slide, please. So the way in which communities of practice were integrated and they function is, as can be seen here. First, the research team made a selection of the settings, a definition of the communities of practice members' profiles, and then we met with health authorities. We set meetings and agreements, and this was an iterative process in which the meetings enrich what had been decided for the selection of settings and the definition of the members' profiles. Next slide, please. After this was done, the health authorities made a call for the communities of practice integration, and after the call, we had a first meeting with 2 main activities, the definition of objectives and the definition of the working modalities. These stages were the ideal stages to identify the champion and the facilitator. Next slide, please. So concerning the definition of objectives and working modalities, first of all, we can see that the objectives of these communities of practice were to identify the maternal health programs implementation problems and to design and execute an implementation research protocol based on the tacit knowledge and the scientific evidence that the communities of practice were able to develop. We had 2 main working modalities. This was a mixed methodology. We worked with insight workshops with the communities of practice, and we also had online activities. These online activities were basically concept mapping on a special platform that was built for this. This concept mapping was particularly related with the identification and prioritization of maternal health implementation problems. And then we also had Facebook pages where the communities of practice could meet and make all kinds of exchanges. During these activities, we were able to identify the community of practice leaders. Next slide, please. So this is what the communities of practice were doing during the almost 2 years that the project went from. So they identified and prioritized implementation problems, as I mentioned. They all participated in an implementation research and evidence-informed decision-making training workshops and Facebook pages. They all elaborated these implementation research protocols. They conducted a systematic review of literature to support the protocols. So these helped them redefine the research question and finalize the protocols. From these protocols, they were also trained to design the research tools to meet the implementation research objectives. And finally, they conducted the implementation research itself. To do this, they had, of course, to apply the research tools. They consolidated the information in databases. They analyzed the results. In this aspect, we realized that since people working in the maternal health programs were not particularly trained to do these kind of things, we needed the assistance of an expert in statistics. And finally, the communities of practice presented the results of what they had done before the health authorities. So next, I would like to know if Miguel managed to join us. Miguel, are you with us? No. Well, since Miguel couldn't join the meeting, I will make a brief presentation of what the Nicaraguan team did. These are the main products and the organization of the two communities of practice in Chontales and Matagalpa, which are departments in Nicaragua. They both developed an implementation research protocol. We can see that the Chontales community of practice worked on the quality service that provide prenatal care to pregnant women in the units of family and community health of the municipalities. The Squash and New Guinea in the community of practice of the Silais, Chontales Silais, is the way in which in Nicaragua they organize health service provision. So we see that this community of practice in Chontales was formed with a facilitator who was a medical doctor who had management responsibilities, and most of the members were primary care personnel, doctors, nurses, management personnel, people involved in communities and other institutions. We had three women leaders and 2 male medical doctors. In all, they participated in 10 workshops with 22 people every time. 4 were with the community of practice leaders and 6 with all the members of the community of practice, and they all participated in the Facebook pages. The Matagalpa community of practice developed an implementation research protocol on the evaluation of the implementation of the strategy childbirth plan in reducing perinatal maternal mortality. As you can see here, they developed 2 quantitative questionnaires and 2 focal groups. They made a literature review in which they found 40 articles, analyzed 27, and used 16 to support the protocol. And as main findings and recommendations, what they presented is that 37.3% of pregnant women have poor understanding of the concept, advantages, and objectives of the labor plan, and they proposed actions to generate a better understanding and empowerment strategy for these women. The health minister instructed her staff to adopt some of these recommendations. Next one, please. So, the lessons learned. What the Nicaraguan communities of practice learned from this process was that there was a very important coordination between the different actors, the community leaders, the universities, the health ministry, and private healthcare, among others, were very important. And maybe one of the most interesting experiences was that the communities of practice were used as a means for disclosure of information and regulations depending on the context, and they were very successful in the management of dengue among pregnant women and chikungunya and other topics of interest for the community. So the communities of practice in Nicaragua didn't only work for the project itself, they also helped in these emergencies that came up while the project was active in Nicaragua. So this is all from Nicaragua. Can we go to the next slide, please? In Mexico, in the Morelos state, I am going to talk particularly about the experience of this one community of practice in order to give you a good example of how things work. We have a community of practice with 34 people that work throughout the whole project. At some moments of the project, we had more than 40 people, but in all, these 34 people work all along the project, 24 female and 10 male participants. The facilitator was someone really engaged, a male nurse who had important management responsibilities, but who did an excellent work working as a bridge between the research team and the people working in the health services. Something very important is that the champion was the chief of all these people working in the program that participated. This is a female physician who had a middle-level decision, who is a middle-level decision maker. Then, among the leaders, we identified 3 female and 2 male physicians. We held 10 training workshops in 22 months, and unfortunately, the Facebook page didn't work as we initially planned. People exchanged very punctual information, but they didn't use the Facebook pages to discuss as we thought that it would be possible. Next one, please. The main products of this community of practice were this implementation research protocol on the implementation problems of the self-care workshops for pregnant beneficiaries of this Oportunidades program on pregnancy risk signs recognition. They developed 4 quantitative questionnaires and 3 focal groups. They made a literature review. They found 61 articles. They analyzed 31 of them, and they used 14 articles to support their protocol with scientific evidence. The main findings and recommendations from this implementation research that the community of practice made is that 40% of the target women do not thoroughly recognize risk signs. So they proposed several actions to improve the quality and monitor the efficacy of the healthcare workshops, And what was very important was that the state health minister instructed her staff to adopt some of these recommendations immediately. This was very, very important and very satisfactory for us all, the research team as well as the members of the community of practice. Next one, please. So now, the key learnings from the whole project is that to develop successful communities of practice, we must assure to have high-level health authorities agreement and support during the project. We absolutely need the involvement of a champion, as I described this person, who has some important level responsibility among the health authorities, but at the same time has enough time to know what the project is doing to facilitate everything for the community of practice to work. And with this person, we need the commitment of a dynamic and respected facilitator. This is someone who is known by the community of practice and who really engages in the project. We need all the members to have enough time to participate. They need to have information and communication technologies, abilities and availability. We need to have direct personal, regular contact of the participants through inside workshops and meetings. And a very important thing is that we need to build respectful horizontal relations among participants and between researchers and the community of practice. Next slide, please. So, the utility of communities of practice is that, as I mentioned at the beginning, they help creating formal contexts for tacit knowledge sharing and organization, for collaborative learning, self-esteem strengthening among participants. And they are very useful in generating interest for an uptake of research evidence. We realized that people working in the health services were no longer afraid of getting involved in research. They saw the utility of participating in research. These were mostly frontline workers who really engaged themselves in doing research activities. And we also managed to generate interest and uptake of research evidence among decision makers in different levels. So this is our main conclusion, is that research uptake, mutual learning and support between healthcare personnel, decision makers and researchers are possible when we apply the proper methods. Thank you very much. The next slide is just something to say. Once again, thank you, and I pass this over to Taryn or John Warner or Nantran in Geneva. Thank you very much.
Thank you very much, Victor. Actually, this is Etienne Langlois. So, muchas gracias. Thank you to you and your team, and thank you to colleagues as well in Nicaragua. If we can put up the slide with the email address, I would just like to remind auditors to, if they have questions, to please send them to the Alliance generic address, which is alliancehpsr@who.int, and we'll have a chance to come back to this, the lessons from the implementation of the communities of practice in both Mexico and Nicaragua, and to address your questions on this. So now we'll move to the next presentation by Taryn Young on the experience in the policy bodying approach in both South Africa and Cameroon. So Taryn, please.
So thank you. I just want to check about handing over the control of the presentation to me.
Taryn, we'll manage the slides for you, so if you would please tell us when to change, that'll be easier.
Okay, great, thank you. Well, good afternoon, everyone, or good morning, wherever you may be. So it's really a delight for me to be able to share our findings from our Policy Buddies project. And with Buddies, for us, it's been a way of abbreviating building the demand for evidence in decision making through interaction and also enhancing skills. And particularly, we were focusing on and building an exchange and dialogue between policymakers at subnational level, as well as researchers with experience in systematic reviews. This is a collaborative project between various partners, including Stellenbosch University, Cochrane South Africa, the Effective Healthcare Research Consortium, with the base being at the Liverpool School of Tropical Medicine, and also the Cameroon Center for Best Practices in Health. Can we have the next slide, please? So I think in terms of just laying the foundation and talking a bit about evidence-informed policy decisions, when we're talking about evidence-informed policy, this is really the approach to policy decision-making that is informed by best available research evidence. And this is characterized by the systematic and also the transparent, both the access to and the appraisal of evidence as an input into the policy-making process. Can you just move one forward? Now, systematic reviews are recognized as a form of synthesis of evidence from various primary studies, and they can be used to consider either the extent of the problem, to consider policy options or implementation strategies, and also to monitor the change that one would want to see with the implementation of policies. One forward. So importantly, there's this gap that we see between the output of evidence synthesis or systematic reviews and evidence-informed decision-making. And this is often in the literature where knowledge translation is being defined as trying to bridge this gap between research evidence and policy. And there's various strategies that are often summarized as the strategies to push evidence, so where researchers push evidence out to decision makers, or to have user pool strategies where decision makers actually request evidence and researchers respond by making that relevant evidence available in a timely way. And then also the exchange strategies that really is about researchers and decision makers working together on an ongoing basis. Next slide. Within the Policy Buddies project, we started out by conducting a situation analysis in both Cameroon and in South Africa at subnational level, really to understand the policymakers' needs and also the factors that's influencing the use of research evidence in policymaking and in implementation. And during the situation analysis, we covered a variety of factors, and we conducted this through interviews with purposefully selected decision makers at subnational level. And we looked at what is happening and trying to understand what's happening in the area of policy development. We also asked the interviewees about their view of priority policy areas and what's the burning issues. We explored various barriers and facilitators to evidence-informed decision-making, and also looked at their opinion for strategies to really enhance the use of evidence in policy development. Next slide. So decision-makers reminded us repeatedly in the interviews that the policy-making we must be mindful of, that it is influenced by various factors, with evidence being just one piece of that puzzle. They emphasize the importance of joint efforts between researchers and decision makers as a strategy to promote the use of evidence. But one of the big things that came out is that they said it's not just about policymakers on the one hand being able to understand the importance of research and the role of research policymakers, but just as important, it's important for researchers to be able to understand the policy environment and really to get to know each other's world, and therefore seeing the importance of working together with mutual trust, understanding about each other's environments. Next slide. So one of the key things that came out from the situation analysis, besides guiding us in terms of the next steps, was also the decision makers asking for capacity development opportunities to enhance their own capacity to be able to clarify research questions and also to be able to find, appraise, interpret, and to consider the use of systematic reviews in their decision making. So we embarked on a series of workshops that were hosted both in South Africa and in Cameroon, where we brought together decision makers. We covered the important aspects of evidence-informed decision making, and using adult learning strategies and a lot of interactive sessions, we covered the key principles and approaches to use to find, appraise, and interpret systematic reviews. And this was very well received in both countries. This was also an opportunity where participants again raised a number of questions that they were grappling with in terms of looking for best evidence. Can you just move one forward? So this is a quote from one of the participants, and I'll read to you. They put forward, "It was absolutely necessary. We as the custodians and the responsible unit for the development of evidence-based policy, and we cannot really add the value that we should without this workshop. For me and my colleagues, this kind of workshop was way overdue." So this was one of our key next steps after the situational analysis. Next slide. The key aspect of our project was really related to buddying. And this model is around creating links between the subnational policymakers and the researchers around specific priority policy issues. This was actively implemented in South Africa, and it was really in relation to those questions that came up both within the situation analysis and also during the workshops. And what we actually did was to go back to those decision makers, and we looked at the questions. We asked them to actually shortlist and prioritize the questions that were raised. And just for two examples of questions, one question, for instance, was around strategies to promote healthy eating and reduce overweight and obesity within the workplace. Another question was around looking at the impact of nurse-initiated and maintenance of antiretroviral therapy compared to medical officer initiation and maintenance of antiretroviral therapy. And these two kind of questions really reflects the burden of disease that we are experiencing in South Africa, which really speaks to a growing epidemic of non-communicable diseases and also the ongoing epidemic of HIV and other infectious diseases. Just one forward. So we implemented the buddying model by linking policymakers to a researcher buddy. And the aim was for them to engage and interact using either telephone calls, a face-to-face meeting, or even email. The buddies kept track of their engagement with the decision makers. They kept track of who they were engaging with, how they were engaging, on what particular aspect were they engaging, and also reflecting on their experience. But one of the key things was that based on the questions that came up, the buddies, in essence, had to clarify the research question. They then had to go and search for existing systematic reviews. And when they found those reviews, they had to summarize it in a tailored way and then give feedback to the decision makers. And in some cases, the buddies actually went afterwards to meet with decision makers, whereas in others, they shared the reports with them by email. Next slide. We had an external evaluation of the project where we used mixed methods approaches, and the evaluation data basically included having a document review of various project-related documents and policies. There was also in-depth interviews that were conducted with policymakers in South Africa, as well as a focus group with researcher buddies and interviews with the researcher team in Cameroon. And the aim of the evaluation was to describe how the intervention was implemented, barriers and successes during this implementation and uptake, and also some learning strategies that were developed in the process. And overarchingly, to describe the impact of the intervention on the policymakers' use of research evidence to inform decision making. Next slide. So I want to share with you some of the data from South Africa in terms of the evaluation findings, and In terms of a baseline that we were working from, there was already a culture of wanting to use evidence in decision making and some demand for evidence use, and that against the backdrop of the expressed barrier from the decision makers that they don't have time to go and find and interpret research evidence, really opened the door and allowed the policy body's intervention to access by decision makers. The budding process of engagement took a lot of time, and it also required bodies to be flexible in how they engage decision makers and the type of tailored summaries and approaches they use to communicate the evidence that they found. The researchers really appreciated the opportunity to learn about the policy-making process, and they found it very useful to learn more about the worlds of decision makers. One thing the researchers weren't always ready for, but it was an eye-opener for them, was policymakers were not just interested in the effects of various interventions or strategies, but they also wanted to know more information and other types of evidence. And it allowed the researchers to grow and try to reach others to be able to find that evidence to feed it back to the decision makers. One of the quotes that I've put at the bottom of the slide was really that as a research study, I learned that we've had much to learn about the decision making in a government environment. In terms of the use of evidence itself, it was particularly useful when evidence could be used to back up decisions that wasn't really universally agreed upon, or when it provided confidence when actually being challenging existing policies and wanting to change those particular policies. Next slide. So I see my colleague from Cameroon, Pierre, hasn't joined yet, so I will just speak through the Cameroon findings as well. In Cameroon, following the workshop on finding and using systematic reviews, there were a variety of priority questions identified during that workshop, and the research team in Cameroon responded afterwards by providing evidence for these questions back to the decision makers. Even after that process, there was then limited engagement following a vision of evidence based on what emerged from the workshop. And in trying to understand why this was happening, a few things came up. One of it was related to just how the differences between subnational and national level in terms of the level of authority. So most of the authority for policy development is at the national level. There's also quite long planning cycles that are in place and that needs to be considered in influence the policy-making process. And there was also competing priorities in the sense that there was a big drive, for instance, related to the immunization campaigns, which were put top of the list in terms of priorities and didn't really allow a lot of room for engaging other strategies or new strategies to be considered within policies. Next slide, please. So just in terms of a summary of some of the key lessons, I think first and foremost for us is that the relationships opened a door for mutual respect and for learning. I think the biggest outcome for us was the importance of the dialogue with decision makers and the way the researcher body benefit from learning more about the policymaker world. I think one is very quick to sometimes criticize the policymakers are not understanding the value of research, but from the researcher side, we also need to understand the policymaker world. What really strongly was that they need flexibility in how we respond to decisions and being able to have tailored approaches for providing the evidence back to them. And one key that we found is that the funding that we had for this dedicated project could devote dedicated time and resources to make it a success. And to stay in the progress, one needs further time and resources to continue influencing decision making as we've done with the project up until now. In terms of providing evidence do play an objective and neutralizing role in terms of consider powerful experts, which especially emerged where we had questions linked to clinical guideline developments. And within South Africa itself, we've seen big spin-offs for the policy bodies project, where we started at the subnational level, but it's really been escalated in some cases to a national level, where we've been asked to work with national decision makers, and where we've also been given opportunities as permanent members of, for instance, guideline development groups at subnational level. We have seen, however, in comparing South Africa and Cameroon, that the context does influence in terms of what is possible. So in terms of considering transfer to other countries, one really needs to consider the context-specific issues. Next slide. So in conclusion, for us, I think the biggest lesson learned is a thorough understanding of how policy processes and how systems operate, and also what the priorities are for policymakers, can inform effective dialogue between researchers, those engaged in systematic reviews, and also decision makers in the health services. Let's move one on. Promote and relate researchers and policymakers, enhancing the use of the evidence within decision. So thank you very much for this opportunity to share what we've done, and we acknowledge the funding that we've received from the Alliance. We thank all our participants and collaborators, and also we thank PATH who conducted the external evaluation for us. Thank you.
Great. Thank you very much, Taryn, and thank you, Victor, for those very relevant insights in the implementation of the respective models in low and middle income countries. It's interesting to see the differences and the commonalities as well in both models. And so I want now to address the issue of some of the key lessons learned across settings, and this stems from an exercise that we did with the investigators for both the policy buddy and the COP model. Next slide, please. And so the results from the from this exercise of lessons learned have been developed as an article, and it's now under review with Health Research Policy and Systems (HARPS). And I want to start off by quoting one of an excerpt from the external evaluation from the Policy Buddies initiative in South Africa, whereby policymakers were empowered by the policy buddying to recognize the value of research evidence to their daily work, and ultimately this process fostered greater demand for it. And this stems from an experience whereby from systematic reviews, policymakers actually demanded more types of evidence, and they asked for implementation research findings as well as operational strategies to help improve the implementation and the development of health policies. And so I think it speaks to this point that Taryn mentioned about the importance of developing in an appetite for science, a culture of evidence whereby scientific knowledge is really looked at when developing and adapting policies. Taryn also alluded to the importance of empowering policymakers to demand, appraise, and use evidence. I very much liked also this aspect of the model in Mexico and Nicaragua based on the 4A models to access, appraise, adapt, and apply evidence. So empowering policymakers is really of the essence, but it's not a one-way street in the sense that researchers in engaging on an ongoing basis with policymakers are also empowered, and they also develop their own capacities and abilities to translate research findings, but also to make sure that the evidence is policy relevant so that they're actually more amenable to transfer those products to inform policy making. So again, on the question of engagement between researchers and policymakers, the issue that we learned is really that this needs to be timely. It needs to be from the onset. But in order to really build this crucial ownership of decision makers, there needs to be some form of ongoing engagement, continuous collaboration, and really a process of iterations that really is sort of tailored to the evolving nature of policy planning and implementation. Those are policies and health programs that are developed and adapted in real-world context, and so the fact that there's a continuous engagement across the collaborative models in the COPs and the policy buddies really help sort of build this trust, this relationship between stakeholders, and really sort of foster the ownership of decision makers. Next slide, please. Now, another lesson, another learning from across the models is really about the importance of having fit-for-purpose approaches. Taryn mentioned the challenges of working with provincial policymakers in Cameroon, for instance, whereby they might not have the same authority to act or the same agency to bring about changes in policies vis-a-vis national policymakers. In summary, it's a question of capability and agency of stakeholders, but it's also a question that's related very much to the type of evidence that is needed with regards to different decision-making cycles or different policy steps. So again, on the importance of fit for purpose, you have here a comparison between the policy buddies and the COP model. And in summary, when we talk about different evidence for different needs, if we take policy buddies, for instance, it was really focused on policy planning, development, and adaptation, while the COP model was targeted the implementation of maternal, child, and neonatal health programs. So basically, the type of evidence that is needed varies. So for policy planning, systematic reviews and derivative products evidence syntheses were of the essence, as in to better understand the implementation of health programs, tacit knowledge, local contextualized evidence, as well as implementation research is really crucial. So I think one of the key lessons, again, is really to make sure that we have a fit for purpose for the evidence, but also a broad knowledge base that includes both hard and gray and scientific literature, but also gray literature and tacit knowledge. And Victor mentioned the formalization of tacit experiences and issues around the concept mapping. So those are interesting way forward to take stock of tacit knowledge. Next slide, please. A few other lessons that we learned with regards to leadership. I think what was crucial in bringing about more use of evidence to inform policies was really those champions and those leaders within health systems who were able to create a receptive context for change and really to create an environment that is sort of evidence-friendly or that welcomes and demands evidence. So leadership is crucial for this in this regard, but also to manage the e-health platforms that were used in both models. So obviously, in Mexico and Nicaragua, it was focused on communities of practice, but in South Africa and Cameroon, we also used an Easy Collab platform, so an online SharePoint that was managed by the investigators in-house at WHO. So it was crucial. Leadership was crucial to the success of those e-health platforms. And then a few words, and Victor alluded to that, on institutional structures. I think what we learned also is that there's a need for better processes within health systems to incentivize the use of evidence. So if we are able to develop structural processes and formal institutional incentives for the integration of knowledge, that would be also an interesting way forward for evidence-informed policy making. And then coming back to this question of real-world issues and complexity, I think it's important to take into account that decision-making processes are embedded in a complex health system, and we need to take stock of the power dynamics that are inherent to health policy making. So in exchanging with the investigators and thinking about the lessons learned, one of the things that struck us is that too often traditional knowledge translation, for instance, act as either a one-stop shop or they're an ad hoc activity that is bound by time. So for instance, one policy brief or one policy dialogue at the end of a specific research project, whereas what we learned in those in implementing those collaborative models is that a ongoing continuous engagement between policymakers and researchers is really key in understanding and grasping the complexity. Next item, please. So I want to leave you, and this is very much related to this issue of complexity science, with a quote by Albert Einstein, who said that we cannot solve our problems with the same thinking we used when we created them. So I think the key message here is to really embrace the complexity and make sure that knowledge transfer and exchange is, to the extent possible, embedded in real-world decision-making. So thank you very much. And with this, I will now move to the question and answer periods. And so I'll take, now we've received many questions by email, and I'm just looking at one question. I'm trying to find one that I had. Here it is. So the first question is for Victor. It's regarding the types of researchers that were involved in the communities of practice. So the question is the following. If I understood correctly, researchers were a separate group of people in addition to the COP. Is this correct? Who were the researchers interacting with the COP? Were these the people responsible for the entire project? So on the issue of researchers, Victor, please.
Yes, indeed. It was the two teams of researchers, one in Mexico and the other one in Nicaragua, who were a different group of people compared with the COPs. And so it was us who were guiding the whole project, who were in charge of the workshops and in making all online platforms work. And so yes, the answer is yes. This was a different group of people.
Okay, great. Thank you, Victor. The next question is for Taryn. Again, on the issue of the sort of profile of researchers involved this time in the policy buddying approach. So the question is, what kind of researcher are we talking about in particular? Were they primary researchers, systematic reviewers, guideline developers?
Thanks, Etienne. So the research buddies were really those who were involved who have been involved in conducting systematic reviews, so who understand the field of research synthesis, and were also those who were keen to promote the use of evidence. So they've had some experience in getting involved with knowledge translation activities as well.
Okay, thank you, Taryn. Coming back to the experience with the communities of practice, the following question is on the systematic review process. So what was the purpose of the systematic review that was performed for the various implementation research projects? Did it add value that was worth the resource investment?
Oh, surely. Yes. This was a very, very important experience because this was an opportunity for the people who were working in the health services to see how something that had come out from their tacit knowledge in the identification and prioritization of implementation problems could be supported by the work done by researchers who had published articles on the different subjects that they had identified through their own experience. So this helped them realize that the relationship between their own experience, direct experience from their work, and what researchers have been doing for years is very important, and that these researchers have produced knowledge that can be very useful for them to clarify and to support what they are looking at as implementation problems.
Great, thank you, Victor. And one last question regarding, again, the Mexico and Nicaragua experience, but this time on the experience using Facebook. So, and Victor, you alluded to that and to the limitations. So the question is specifically on that matter, what are the advantages and disadvantages of using Facebook for this purpose vis-a-vis other tools such as D groups or LinkedIn? And what is the different experiences from various communities of practice in this regard?
Well, what happened is that what we realized that the social media provide something that that people are quite acquainted with, and this is why we didn't want to use something more specialized as LinkedIn. And since almost everybody now has a Facebook profile, and we thought that this would be a means to make them get into another way of using the social media. But unfortunately, what we realized is that people would find it very, very difficult to identify the difference between using Facebook for working purposes instead of just exchanging information or saying hello to their friends and this kind of stuff. So Facebook worked very well for everybody to get in touch when they had to be at a particular time, at a particular place to attend a workshop. But what we were trying to do was to foster discussion among them, and this didn't really work. Discussion was much livelier, was much more interesting when we did it during the workshops.
Great, thank you very much. And with this, I think this will close the webinar since we're out of time. So thank you to all presenters. Thank you to everyone present, and to all my colleagues here at the Alliance who helped with organizing this webinar. And until next time, thank you very much.
Thank you very much, Etienne. Thank you all.
Thank you. Thank you.